He is a consultant in emergency medicine in Wrightington, Wigan and Leigh Teaching Hospital. He is the president of the British and Irish Pakistani Emergency Physicians Association, and I would like to hand over to Professor Abbasi.
Thank you very much, Ahmad, and apologies for our delayed start. As you know that sometime technology plays its part. But welcome everyone for this series of webinars that BIPEPA are arranging for especially for the trainees, but it's for anyone, you know. It will be a bit different rather than having the clinical conditions like asthma or COPD or other related diseases. It is more sort of a management, you know. And I think as a doctor, we are treating patients, and sometimes we make decisions, and those decisions have got a big impact on patients. So this is something which I've created in the last few years. That not few years, I'm 40 years as a doctor, and out of those 25 years as a physician. You know, so these are some lessons learned from the patient safety incidents in the emergency department. And I attend every week something which is called as LFPSC, which is learning from patient safety incidents. And these are some cases that I brought to share with you. So the objective of this session is to learn from our mistakes and prevent recurrence, to avoid human suffering caused by our mistakes, to reduce the cost of litigation in our trust and the NHS, to give our patients and relatives the high quality service that they rightly deserve. And I usually say that we need to give the same service to our patients which we deserve for ourselves and our family. And that is the baseline. And last but not the least, to give feedback to clinicians involved in these cases for learning purposes, which happened in our trust, you know. So when we talk about the litigations or the money paid when the mistakes happened, but remember that on the other side, we are talking about a human being, you know, okay? And any of our mistakes have got a big impact on these human beings. So this is a life cycle of a human being, of a person, of a patient, you know, starting from birth and having bottle fed, and then going to nursery, school, and then to the high school, college, and then working life. And at the end, probably you can see myself, because this is something after retirement. You take up golf and start enjoying your life, you know. So any mistake which can cut short this cycle is devastating. You know, not only for the patient, but also for the family, you know, okay? And this is the cost that if something happens to a child, you can see that we basically cut short his life for almost 50, 60 years, you know. So be careful when we are treating our patients, yeah. You know, you all remember that when we were in school, when we were in college, we were very bright students, you know. That's why we went into medical school. The cream of that, any class or any school or any college goes to medicine or pre-engineering, you know. And we are quite stressed when a mistake happens. We want to deliver the best quality service to our patients. And when we do something silly or there a mistake happened, it creates a lot of stress. And to be honest, not in these cases, but there are mistakes that it happened to me as well. And sometimes you go in your office or somewhere in the side of the corridor, and you shed some tears that why this happened, you know, and it shouldn't have happened. And the stress and anxiety of a doctor, you know, after a mistake happened by them, has a huge impact on our working life. So the best thing is to avoid it, not to happen, you know, okay? And that is why we have to learn from the other experiences rather than making a mistake by ourselves. So again, As you know that the money is important also to run a service. So the NHS, when I joined in 2001, at that time they were spending around 50 billion pound, and now it is more than 200 billion. That's probably the whole budget of the Africa, you know. So it's a huge amount which I was spent. But if we say that how much it is spent on the clinical negligence, it's more than 3 billion pounds. So you can build a hospital by 3 billion pound, you know. And as you can see that when it is growing higher and higher, and for that matter, in the NHS paid about 2.4, 2.8 to 3 billion in clinical negligence claim in 2018 and 19. And this is according to the data from the NHS Resolution Authority. After 2019, there were 2-3 years when the litigation went down, and that was because of the COVID, because nothing happened. Everything was basically put it as COVID related. But having said that, just 1 minute, I think I lost it. Yeah. So um, this is a huge amount, and there is a saving. But remember, from my point of view, no money can bring a patient back to what happened. You know, if somebody has lost a limb or somebody has lost a life, you know, it is you cannot count that one into billions or millions of year pounds. So human cost is much more as compared to your money. But even then, from my point of view, yes, the litigation pays a lot of money to for the mistakes that the doctors and nurses are committed in their working time. This is probably my favorite slide, you know, and as you can see that the plenty of resources are available, but a person is not aware of those resources, and it doesn't matter how many resources you have. If you don't know how to use them, they will never be enough. And that's what I'm saying, that starting from 40 to 50 billion, we have increased to 200 billion. But at that time, 98% of our patients were seen within 4 hours. Almost 100% patients were seen within an hour of arrival in the A&E. And you see now we are less than 50% people are seen in 4 hours. So huge difference in spite of so much money spent, you know. So we need to use our resources intelligently to avoid this breaches, you know. And word of wisdom, and one of the most famous son of West, you know. And Albert Einstein said that insanity is doing the same thing over and over again, expecting the different results. And I'm absolutely right, you know, that you have to think about it if some things are not working. And we know that the NHS problem at the moment, and we go every day and do the same thing. And I don't think so that any different things will happen if we don't learn from these experiences, you know. So now I'm going to go to the cases. And so these are the experiences I had, and I want to share with that one. The first one is a 47-year male who came with the chest pain. So this was the case which 28th of August 2015 presented with a 2-day history of chest pain and generally unwell, diagnosed with rib sprain. And this patient was seen by a senior doctor. When I say senior doctor, it was one of our middle grade, you know. And this patient was working with his son and basically decorating his home and doing something with the ceiling. You know, I think that they were doing the paint and started the chest pain. And he came to the A&E. And so he was discharged with the rib sprain, traumatic sort of chest pain. And the patient came back on 29th, and with the full fulminant left ventricle failure, with left bundle branch block on ECG. And so when I investigated these two presentations, one thing which was very obvious was that on 28th of August, this patient had a chest X-ray. And the clinician who was dealing with this patient did not wait for the X-rays to sort of report it. Did not see himself. There is no documentation whatsoever that he basically saw that one, because he would have saw that one. He would have seen the signs of heart failure on the X-rays, and unfortunately didn't do that one. The second thing was that there was no ECG done. I mean, obviously, he was more yeah, directed that it is rib sprain, and unfortunately, didn't do the ECG. So there was no ECG, and there was chest X-ray which was requested. Maybe he was thinking about the pneumothorax or something else, but he did not see the result of that one. And unfortunately, the patient came back within 24 hours with the deterioration and basically went on and was admitted under us, and then we shifted to Manchester, and unfortunately, the patient died. I remember this patient. The reason is that this was a gentle joint, and Mavish and myself, we work in the same hospital, and the first person we see when we go to the hospital is security staff, and they have got a quite a good relation with us as well. And he used to say to me, "Hello, Mr. Abbasi, how are you?" So, I mean, I felt it very, very personal, and I was really devastated, that he was not that old. He was only 57-year old, and it was very unfortunate. And he could. I will say that probably from my point of view that it was avoidable death. That if we would have diagnosed, because he came with his family, in his own car, he was not that sick. If we would have diagnosed early, 24 hours before, we might have sent it to for PCI and to the regional center, and could have saved that one. So lesson to learn is all chest pain should have a baseline ECG. We do it, honestly from my point. Sometimes we know that even the tenderness is there, so teeth syndrome and all that, but we say that the basic ECG should be done for all chest pain patients. And the other thing is the X-rays. If you advise any investigation, it is the responsibility of that clinician to see the result. This is the GMC guidance, so both of them mix. And how much the trust has paid? £750,000 was paid to the family, But remember what I said before, human cost, unmeasurable. He will not see his grandparents. Grandparents will, grandchildren will not see a grandfather. A wife has lost his husband, and the children has lost a father. So the human cost is unmeasurable. Now the second patient is 18 years old male with the headache. So synopsis is that a delay in the diagnosis and treating a suborganized cyst and subdural hematoma. So this case attended in AD on 28th of July 2013 with worsening occipital headache, photophobia, and neck stiffness, initially assessed by a junior doctor. And a junior doctor basically said a differential diagnosis of subarachnoid hemorrhage or meningitis as a suspected diagnosis. A middle-grade clinician then reviewed the patient. By this time, there was no photophobia. Pain score had decreased from 8 to lower, and there was no neurological symptoms as well. So attention headache was diagnosed, and the patient was discharged with analgesia and antiemetics. Attended his GP on 29th, but then very next day, and 30th July, after the 2 days, due to persistent symptom, and was referred and admitted to Bolton on 1st of August. And an MRI scan showed a large left subdural hematoma communicating with a large organoid cyst. Patients transferred to Salford for emergency neurosurgery to evacuate the hematoma. So, from my point of view, is that initially whoever is assessed, and that was a junior doctor, and very rightly, right, the differential of subarachnoid hemorrhage or meningitis. Then usually what happens is that when if somebody has got a pain score of 8 or 10, we give strong analgesia, and it's sometimes it's better, occipital headache, worst headache at the start, and so thunderclap sort of a headache. So these were the things which the junior doctor was thinking. But when the middle grade went and assessed that patient, he thought that the pain is better, and there is no other photophobia and all that. But this is something, 3 to 4% of your patient every day present with headache. This is not the first time we have missed, and probably not the last time. But it's always better to be safe rather than sorry, and unfortunately, this is what happened. It was overruled. We did not do anything, and it attended another hospital, and there it was diagnosed as subdural hematoma. Okay, so what was missed? Failure to act upon red flag features of headache, patient discharged with no imaging performed. Lesson learned, not to be dismissive to your junior staff and always look at the red flags. And these are the things which I have already said, that we missed it. Not only that red flags, but also a junior doctor made a right diagnosis and it was overruled. Discussed in clinical governance and feedback was given to the doctors, but how much we paid is 900, almost £1 million, 900,000 pound. And the reason is basically, this patient was only 18 years old, and so he has got a full life. So when they calculate the expenses, they calculate that how many, the average age is more than 80 years. So that patient would have lived that long. And so this is all that money is given, calculating that what's the lifespan and how much that person could have earned, Okay. Now, this third case is 37-year-old male and hip and leg problems. Synopsis is failure to treat and diagnose a spinal cord compression in a timely manner, resulting in patient attending another hospital and requiring surgery. This was in November 2015, and attended A&E with the left hip pain, cellulitis, right thigh, and pins and needles in both hands. Left leg had given way and he had fallen to the floor on a few occasions. On examination, pain on internal rotation of the left hip and an area of erythema, cellulitis on the right thigh. So hip X-ray moderate to severe osteoarthritis impression, arthritis left hip plus thrombophlebitis, prove mobility reviewed by the X team, X is the mobility assessment team, and patient advised elbow crutches and then discharge with an orthopedic follow-up. So what are the things which I'm not doing this face to face. I can't ask you to tell me, but there is quite a different, one is basically the hip problem, but the other one is basically pins and needles in both hands. So was it completely ignored? Why did somebody didn't do the examination? When somebody means a doctor, So one of the things which I looked into the notes, there was no neurological examination. So there was no documentation that the doctor basically examined the neurology. So on 24th November 2015, attended A&E again and reported that he was awaiting a left hip replacement, and for the last 5 days, both legs had given way and he felt weak. He also complained of feeling tired, weakness in the arms, and his family had a history of motor neuron disease. Told the doctor that he felt generally unwell and had numbness in both arms and legs. He was advised to see his GP about generalized weakness and was discharged. On 2nd December, so this is going on now for more than a week, attended a planned orthopedic clinic for review of his hip. He reported that he had developed weakness of his leg and numbness of his hands and feet and has incontinence. So obviously it has the disease has progressed. He was advised to attend the emergency department at Salford Royal Hospital, where he was admitted. An MR scan was performed which showed compression with a signal change at C6 level. On 9 December 2015, he underwent an anterior cervical discectomy and a fusion of C6. So what have we missed here? To carry out further investigation during attendance at A&E, no adequate record of history of reported symptoms of pins and needles in both hands. No history was recorded of onset or duration of exacerbating and relieving factors or any associated weakness in other areas affected similarly. to elicit that there had been progression of symptoms and that they had been sufficiently severe to prevent the patient from working, to perform any educated neurological examination of hand function, power, and sensation. So there was no documentation. And remember, even if you have done it, if you are not documented, it's not done. No court of law will accept that one, that if you're not documented and you say that I have done it, they will not believe it. So a thing which is not documented is thing which is not done. So make sure that your documentation is quite legible, and you document whatever you have done in the examination of the patient. And it should be done always, because sometimes these cases come after years and you will not remember that one. So always remember that whenever you are examining a patient, just document that what are your findings. To heed and record the claimant's complaint of urinary bowel dysfunction, which would have been additional reason to admit for MRI scanning or spinal surgical referral. So, lesson learned, adequate history taking with complete examination, requesting relevant necessary investigation and proper advice on discharge, which is safety netting. How much damages our trust has paid to this patient? £750,000. So if the first three cases that I have presented here, if you combine that one, it's probably near to 3 million. And with the £3 million, you can have at least, in my opinion, 50 nurses and at least 10 or 15 doctors. You can employ that, and that would be great help for to see patient. And similarly, the other things that we do in our department, equipment, so a huge amount of money. And if you have seen these cases, and if you go through the notes and investigate that one, they all were preventable. They are mistakes committed by us. And when I say us, I have done in my lifetime as well. So you feel sorry, you have sleepless nights, you have nightmares, your mood to your family is different. Sometimes you get jittery. It's all because of the pressures. But having said that, if you want to be, safe, then you need to learn from these safety incidents, because that's the idea. You don't have to go through yourself, because I am telling you, it's terrible to feel when you lose someone or when you do a mistake and some harm happens to the patient. So this is a female patient with abdominal pain, synopsis: failure to diagnose and treat a small bowel obstruction, which led to the patient's death. So the case summary is 15 October 2016, abdominal pain and collapse, abdominal bloods and abdominal x-rays, chest x-ray and fast scan done. Abdominal x-rays not reviewed by the clinician, and the patient was discharged home. So abdominal pain, we don't do much of the abdominal x-rays now. But having said that, and previous presentation, that previous case, I also said that, that if you done and requested an investigation, is primarily your responsibility to see the result. If you have not seen that one and there is a finding in that, then GMC will hold you responsible that it was your primary duty. When you request something, then you have to see as well. In A&E, sometimes we do investigation, refer a patient to the other specialties, and then forget. But having said that, always if you're hand over, just write down that you have handed over and you said to the specialties that these are the bloods are investigation waiting and can be looked once they are back from the system. So you need to document that one. On 17 October 2016, represented with the abdominal pain and vomiting, tachycardia. So after 2 days only, and no low sat. Reviewed by medical team, working diagnosis constipation. Previous abdominal X-ray 15th October was reviewed, showed dilated loops of small bowel, suggestive of small bowel obstruction. So this was on post-take ward round. He was admitted under medics because we thought that it's constipation, the A&E. But when one of the consultants in the post-take ward round saw that there was an abdominal X-ray done, so he reviewed that one and he thought that there is a small bowel obstruction. Urgent CT scan, small bowel obstruction was with perforation. So IV antibiotics, IV fluids, reviewed by a surgical registrar, advised surgical intervention. Later, surgical consultation attended ward to review patient. He vomited, feculent vomitus, and then suffered a cardiac arrest. No return of spontaneous circulation throughout 9 minutes of EPR, and decision was reached to call. So cease further attempts, and patient unfortunately died. Was it not unfortunate? We can't say. It might be that she was elderly lady. She would have died anyway. But then 2 days we have discharged this patient and didn't see the investigation. It was a perforation, and then basically it came as a gram-negative peritonitis, and that's the reason the patient died. If we would have started 2 days back treatment, the antibiotics opened up and did these sort of resection, whether the patient would have been survived, we can't say now because 48 hours we didn't do anything with this problem. So what was missed? Failure to review or properly consider and document the results of the abdominal X-ray or chest X-ray, so the patient not referred for surgical review. Intentional rounding and repeat observation of patient were not completed. Failure to reassess the pain score. And one of the thing is consultants on sign off is in line with the College of Emergency Medicine, and these are the people, especially Mavish and Imad are listening to this one. So we have got this one that if you have got an abdominal pain and you have to discuss with the consultant for consultant sign off. You can't discharge the patient, but obviously that was not followed as well. So lesson learned, investigation, X-ray should be reviewed before discharging patient, and results documented, repeat observation and reassessment of pain score needed to be done. Consultant sound of condition, discharge to be approved by a consultant. So damages was only £25,000. And the reason was that the opinion I gave in this case was that probably the patient would have died anyway. And as she was in 80s, so that was not a long life left for her as well. But that again, from my point, is not about money. It's about the cost of the loss of life. And remember, on the other side, I'm saying about the patient relatives and the trust paying that one. But on the one side, remember there are doctors as well. You, me, we see these patients, and how devastating will be if for a doctor, knowing that with his or her mistake, the patient has lost a life. It's devastating. I wish and I hope that none of you go through that basically time period. It is really, really disturbing when you go through that. So a female, 73 years old, leg wound, synopsis, failure to provide adequate infection advice following an A&E visit due to leg wound. And PF is a patient that went home after wound treatment and died as a result of sepsis. I have to quickly, because I have got another engagement at 7, and we have started a bit late. But regarding this patient, and unfortunately, this patient was seen by a consultant. Okay. And the thing which was missed was that she had a wound on the leg, and basically that leg wound got infected. She came from the dressing in the hospital, okay, and after a couple of days, and again further after 2 days, and nobody's opened the dressing, to see that how is the wound, because it was a bit of soakage, and so within 3-4 days, the patient went into septic, and unfortunately died of sepsis. And in this case, the lesson learned is to discharge information given to the patient was not adequate. To ensure that patients are given information what to do if matters deteriorate. Safety netting. Issues with record keeping. Ensuring notes included all issues and actions taken, such as cleaning the wound and noting all contact made by the family after discharge. When the family rang to advise the patient was in pain. Considering of checking observation when patients attended for wound review. Uh, Unfortunately, nobody took took the pulse, blood pressure, temperature of that patient in that one. So it came for dressing. They just saw that one, gave them the dressing, and said that, oh, it looks okay. But if it was missing, so if you have done the maybe for tachycardia, maybe she was a febrile, then the mu scores are done, which is more than 3. You think about the sepsis and all that. So unfortunately, that was not done. So there was a mistake. The damages were again 75,000 pound because of the age of the patient. I think this is the last one. Synopsis: incorrect diagnosis of frozen shoulder and a failure to arrange necessary assessment to exclude septic arthritis or initial admission to the A&E. On 29 January 2016, received a steroid injection in her right shoulder from the GP. Later that evening, the worsening pain in our right shoulder. On 2nd February, presented to A&E, was examined and diagnosed as a frozen shoulder and referred to physiotherapy. On 4th February 2016, presented to her GP again with worsening pain. The GP suspected septic arthritis, arranged blood test, and sent the patient to the A&E again. The patient attended and was diagnosed with septic arthritis requiring IV antibiotics, resulting in articular and articular cartilage damage. So what did we miss in this patient? An incorrect diagnosis of frozen shoulder. So, I mean, if you receive an intra-articular injection and you have a severe pain after that injection, the first thing comes into your mind, from my point of view, working as an A&E. Obviously, I have got a 40 years of experience. Sometimes I don't expect these things from the junior, but a A&E mind should exclude that it can be a septic arthritis. Okay, so we missed that one. We didn't. We thought that it's more of a frozen shoulder because of the steroid injection and the pain in the shoulder. The investigation report case review represented at a trust, executive scrutiny group and emergency care meeting for learning. The report made a recommendation to provide individual clinician with training and to record in documentation with assessing patient. So damages were 60,000. So this is the last couple of slides. And when I'm doing the face-to-face, I usually ask this question that what is common between doctors and lawyers? So a lot of different discussion happens, and people say all different their own sort of versions, But the common thing is that a mistake by a lawyer can put you at least 6 feet higher in the ground in the gallows, and a mistake by a doctor can put you 6 feet under the ground in the grave. So both of these professions are very, very important that we don't do any mistakes. And this is the last. Thank you very much for your patient listening. Apology again for a bit of delay. I will only say be careful, because a mistake when you're playing a cricket, there will be a second inning. A mistake while you're driving can also be, forgiven, but a mistake in a patient will cost either the life or a limb. So for us, it is very, very important that we need to be safe. Thank you very much. Thank you, Imad, for arranging that one, and thank you all. It's another 5 minutes that if you want to have any questions, or you can write it afterwards. And if you have got anything, I will be able to answer you on the email or with the WhatsApp group. Yeah. Thank you.
Thank you, Professor Abbasi. That's a great webinar. I will see if anybody is posting any questions in the chat, but so far just comments that it was a great session and a good lecture, and thank you for the insights. What we're going to do is we will put this up on our YouTube channel so that people who haven't attended or who registered but were unable to attend, there was maybe also some issue with the link that was sent out, so they will be able to watch it. What we will do also is that we will revisit this topic again, and we will try and address the rest of our objectives, which was talking about the patient safety incident response framework, talking about what after action reviews are, what PSIIs are, and all those tools, and talk about how research has actually started to make a difference in the NHS, and we're moving away from the serious incident framework and litigation and investigating just for the sake of completing an investigation and actually trying to learn from incidents. With that, Professor Abbasi, thank you again very much. I will shortly send out the poster for next month's webinar. So I'd just like to explain to everybody that one of the reasons that our webinar had to change its date, it was meant to be on the 2nd of July, was because the CHLO webinar, leadership webinar was happening on the same day. And one of the delays in getting online today is I was meant to be in court and I was expected to give evidence at 10:30 in the morning, but I was still giving evidence at 6 p.m. So thank you everybody who's logged on. Ali, that's a really good question. So why don't I just pop the link here, how you can become a member of BIPEPA. There you go, sir. I hope that this encourages you to join us. We are, at this point, we have options for an annual membership and a lifetime membership. So please see what you would like to do. And once you're a member, please also get in touch with us so that we can get everybody involved in working together to advance emergency care and to mentor other people working in emergency medicine. Thank you once again, Ayaz. We'll call it a close here. There are no questions. You can stop sharing your slide.
Okay, then I will switch off because I have to go to another meeting here.
Yes, no problem. And Ali, I've just put the email as well there for you if you want to contact us. Thank you, everyone. We also have a LinkedIn and a WhatsApp, group, a LinkedIn page, and a Facebook page. So if you contact me by email, I'm happy to send you the links for all of those. Thank you very much, everyone. You have a good day. Allah Hafiz.